Okay, thank you, Rochelle, and thank you, Stuart, for organizing this town hall, as always. And welcome everybody to our Division of Prevention Science, CAPS and TAS Fellows Town Hall. This afternoon, we have the pleasure and honor to host our esteemed professor from Yale, Dr. Ryan McNeil. The title of his talk will be what it is, navigating overdose and structural vulnerability amidst a toxic drug supply. Of course, it's a wonderful, excellent topic, and actually with some connections to us, UCSF in San Francisco. I'll tell you a couple of things about the wonderful CV and record of Dr. McNeil, and then I'll pass the mic to him. Dr. McNeil is an associate professor at the Yale School of Medicine, and he directs the harm reduction research within the Yale program in addiction medicine. Through his NIH and CIHR-funded community-engaged qualitative and ethnographic research, examines how forces operating within the risk environments of people who use drugs shape risk and harm, particularly focusing on the intersection of the changing drug supply and socioeconomic marginalization, which brings a very good perspective, bringing both pieces, the people that use drugs with the changing drug supply. Thank you, Dr. McNeil, for joining us today. After his talk, we'll have about 10 minutes for a Q&A. So thank you.
Let me know. So thank you so much for joining. So today I'm going to talk about the work that we've been doing around overdose vulnerability, the toxic drug supply, and socioeconomic marginalization for really work that's been going on for about a decade, but has become particularly urgent since the rapid intensification of overdose deaths beginning in the roughly 2015. So before I begin, I'd like to say I have no conflicts of interest, but I'd like to share basically a commitment that underlies the work, and that this is work that I do specifically, and that happens with the broader personal, professional, and political commitment to advancing health and social justice. And that frames my interactions with community, how I approach the work, and the things we advocate for out of the work that we're doing, and ways we partner with the community to try to affect change. So specifically, this work happens against the backdrop of an overdose crisis that certainly folks will be well aware of, but that certainly has been framed by the broader transformation that we've seen within the illicit drug supply since the mid 2010s, as we've seen the rapid transformation due to the proliferation of fentanyl and fentanyl adulterated drugs. And I often think back to a quote from a paper that we did early on characterizing fentanyl overdoses and how they presented, that I think both symbolically and materially capture so much of what's happening. And so I'll read, and I quote, "With heroin, you feel it coming on, you feel the intensity, you feel like you're going to puke, because it keeps coming, and I'm going to go down, overdose. Fentanyl, you're sitting there waiting for something, and the next thing you know, there's an ambulance attendant there. It hits you like a Mack truck. You don't feel it, nothing, it's just boom, down. You get up and you swear that you didn't even do your shot, and you're looking for it." And so for me, this quote so much captures the urgency of the overdose crisis, as we've seen the drug supply rapidly transform and fentanyl replace heroin and other opioids through most of North America at this point. This captures the urgency of overdose presentations in terms of how quickly they come on and their broader impacts, but also when set against what in many cases have been the slow death of people who use drugs, as framed by the intersections of structural vulnerabilities, inadequate health care access, higher rates of HIV and hepatitis C. We've moved from a period of things slowly coming on, like a heroin overdose, to the urgency of the moment we're in now, where at any moment we could lose somebody because of just how toxic the drug supply has become. And so really we see this moment where, while an overdose epidemic had been happening throughout North America for many years, beginning, and if you look, and I apologize, this isn't bigger, in 2015, we see a sharp uptick in overdose deaths due to synthetic opioids, primarily fentanyl. And then we see this then rapidly increase at the outset of the COVID pandemic. Now, certainly during this period, we have had long-standing issues surrounding heroin overdose, prescription overdose, and a wave of polysubstance overdoses heading more recently, but certainly the majority of deaths that have been happening since 2015 are involving fentanyl and fentanyl adulterated drugs. We see similar patterns in Canada, where fentanyl since 2016 has really been the primary driver of the majority of overdose deaths. And then during more recent years, we've seen fentanyl-related analogs that are still more potent enter the drug supply with greater frequency, transform the supply, and amplify overdose deaths. Now, certainly, if fentanyl is one side of this equation, what we really see is, much as other epidemics that have come before this, we see it disproportionately impacting people who are socioeconomically marginalized, who are experiencing homelessness or housing vulnerability, who are impacted by criminalization and incarceration, because the very conditions that drove other health inequities continue to exacerbate risks in the context of the overdose crisis. Again, more recently, in the context of COVID, as we've seen still a further transformation of the drug supply, we've seen new psychoactive substances enter the supply, like xylazine, throughout much of the East Coast, and certainly appearing elsewhere across the country, to illicit benzodiazepines, which we've seen in parts of Canada and sporadically in parts of the US, which certainly can amplify overdose risks and vulnerability because of amplifying opioid effects, but can also produce a range of other harms, including vulnerability to gendered violence and the presentation of complex injection-related infections. So the work I'm going to talk about today is primarily located within the Downtown Eastside of Vancouver, Canada, which is an approximately 10-block area in Vancouver, which is commonly characterized as one of the most beautiful and livable cities in the world, according to kind of large-scale quality of life assessments. Yet through the rapid destruction and demolition of low-income housing throughout much of the community through the 80s and 90s, broader efforts that have pushed people who use drugs into what really is the only remaining ungentrified community in this city, we see an approximately 10-block area with, estimates roughly put between 5,000 and 6,000 people who use drugs. It's where we find the majority of the city's low-income housing, primarily in the form of single-room occupancy hotels, similar to what you would find in San Francisco. The vast majority of harm reduction infrastructure, including syringe exchange programs, supervised consumption sites, and still further programs that I'll talk more about as I go on today. And while this community is very much marked by deep marginalization, homelessness, housing vulnerability, people being impacted by structurally racist policing practices, longstanding epidemics of gendered violence, it's also a community that's very dynamic. And in terms of how it's been located in relation to social justice movements, been instrumental in advancing the rights of vulnerable persons, both through strategic litigation, which has led to the protection of services and supports for people who are vulnerable in Canada, but also through direct community organizing that has both expanded and in many cases contributed to the evidence base of innovative interventions for folks who use drugs, like supervised consumption sites, before that, syringe exchange programs, and more recently, safer supply programs, which we're seeing now implemented on a modest basis. And so there are really three questions that kind of will structure out the work that I'll be speaking about today. The first is how are ongoing changes to the drug supply intersecting with social structural conditions to frame overdose vulnerability among structurally vulnerable people who use drugs? The second, how are these dynamics shaping the implementation and effectiveness of the overdose response, including novel interventions, which I'll speak more about? And then finally, what does this tell us about the changes that will be needed to address the overdose crisis? So in terms of the broader program of work that I'll draw upon, it's a program of community-based research that I've been leading for a number of years that really seeks to take direction from the community in terms of research priorities, processes, and alignment with broader organizing goals. And this is very much informed by work that we'd done early on, engaging with folks who use drugs about what needs to happen in research in the Downtown Eastside of Vancouver, which for folks who may be aware, might be the single most researched neighborhood in the world, with quite literally thousands of papers being produced, certainly with us contributing to that through our qualitative and community engaged work, but there being longstanding cohort studies, intervention studies, and a range of other things in the community, leading this broader perception that this is an over-researched community where researchers have come in, taken, and not contributed in a meaningful way to material improvements for people in this neighborhood. And so engaging with people around the ethics of community engaged research focused on substance use in the Downtown Eastside, this really drew out the extent to which relationships need to be reciprocal. There needs to be alignment between what we look at and community need. The work needs to be in service of the community, and we need to find meaningful ways to integrate people who use drugs across and throughout the research process. And then for me, what this has meant is leading and developing a program of qualitative and mixed methods research that seeks to address community priorities through partnerships and the meaningful involvement of people who use drugs in all stages of the research process. So in terms of research idea generation, this involves deep and ongoing consultations with community partners that include grassroots organizations made up of folks who use drugs, people engaged in treatment programs, tenant organizers, sex workers, and others around what are the problems in the community that we need to respond to that research evidence could be helpful for. This involves, as part of this co-generation of research ideas, identifying ways for the community to be meaningfully involved. This means co-designing work, co-developing research materials, processes, and data collection tools. This means creating space on teams and compensating people who use drugs to join as investigators to contribute their lived expertise in relation to substance use and socioeconomic marginalization to the work that we do, so that it is grounded as best possible within the broader context of what it means to be in the Downtown Eastside. This involves striking strategic partnerships with other organizations where we can intervene to promote better conditions in, for example, single-room occupancy housing, whether it be nonprofit run or privately operated. This involves building out relationships with a range of other partners so as to best affect change and line up our work with the community organizing that's happening so that research evidence can be translated into advocacy strategies in real time. So the work that I'll talk to you about today will primarily be work that we've done in relation to NIH-funded project that we've been running in the Downtown Eastside since 2017 that involves the deployment of primarily rapid ethnographic and longitudinal ethnographic methods in relation to a handful of harm reduction organizations and drug user-led organizations in the neighborhood, as well as work that makes use of a broader cohort study for the purposes of more refined work. So overall, since 2016, when we began this work, we've undertaken hundreds of hours of ethnographic observation across a range of different sites, from intervention sites, like clinics where low threshold medications are delivered for the purposes of treatment or safe supply, to work in overdose prevention sites, on through to work happening across a range of drug scene settings, from single room occupancy hotels to alleyways to everywhere in between. Still further, this is work that has involved interviews with more than 700 people who use drugs over this time period, surrounding their experiences in relation to the overdose crisis, framed by their structural vulnerabilities, and in relation to specific interventions that we may be studying at any given time. So these folks have been primarily recruited through peer-led harm reduction organizations, by peer researchers working within our program. This has also involved co-interviewing with folks from the community who are part of our team, as well as strategically making use of existing cohort studies that operate in the neighborhood to reach folks who may have specific sets of experiences or outcomes that are difficult to identify through community-engaged recruitment. So specifically our sample, we oversample women and gender minorities as part of the work that we're doing. And for any given study, 40 to 50% of our participants will be Indigenous folks who use drugs, partly due to our commitment of ensuring that we reflect their experiences and the specific intersections of settler colonialism and the drug war in framing their lives and engagement with the interventions that we study. Given the disproportionate impact of the overdose crisis on Indigenous people who use drugs, as is consistent with the intersections of structural racism and the drug war worldwide. Still further, this work and research is then looked at through an intersectional lens, which we've developed over time in the course of doing this work, wherein we're specifically focused on effectively how we might understand differential experiences within the risk environment of people who use drugs as shaped by assemblages of social positionalities from race to gender to age to class, sexuality, and so forth. And here we're specifically interested in how social, policy, physical, and economic environments create unique assemblages of risk that impact on particular population across axes of oppression. And that this work in turn becomes social justice oriented in specifically focusing on the structures and social conditions that drive differential risk and harm across and within drug-using populations. So in terms of the specific work that I'll talk about, there's a number of key points that I wish to reinforce that have emerged through this work. And certainly first, that changes to the drug supply are reshaping drug use practices as people who use drugs are navigating drug use and overdose risk amidst uncertainty and socioeconomic marginalization. And so certainly we can understand these moments of drug supply transformation as critical moments in time where we see the remaking of drug use practices set against the backdrop of amplified risk. So for example, early on, as the drug supply was first transitioning, we were engaged in work looking at processes of injection initiation among people who use drugs. And one of the interesting dynamics that emerged is while practices surrounding folks receiving injection initiation assistance in relation to drug use are well documented and often structured by economic imperatives that lead injecting to be particularly attractive. That is, that you can get the most bang out of your buck when injecting, and when using drugs within the context of economic uncertainty and marginalization, that doing so can be attractive. And yet, as the drug supply became remade, as fentanyl became introduced into the drug supply and became really the dominant opioid that we saw those patterns reconfigure as people became less likely to initiate others into injection drug use because of the fears associated with effectively causing an overdose event or leading someone to overdose. As more broadly, we saw drug use practices being remade within the community more generally, as more people began to transition to smoking drugs primarily, which certainly you've seen in San Francisco over the last number of years amidst this drug supply transition, but also people began using drugs in different combinations. Certainly here we saw a rapid rise in goofball injecting, which is the co-injection of fentanyl and methamphetamine, due to the perception first that injecting methamphetamine could be protective in the event of the overdose caused by fentanyl, but also to produce particular drug effects made necessary by fentanyl and how quickly it can be metabolized by people. So here, one of the primary things that we would see is people talking about specific sets of drug effects. That is, I'm co-using methamphetamine alongside fentanyl because it helps stretch the fentanyl out. Which, if I'm just using fentanyl in that context, I may be injecting every couple of hours, which is much more frequently than the 2 to 3 times a day we historically saw with fentanyl injecting. Here's a quote from a participant speaking to this dynamic. Like, the fentanyl doesn't last long. It's like a really short lifespan, and you have to use more, and you're spending more money than you were when you're doing heroin. When you're doing heroin, it lasts like 6 to 8 hours or a while. And this stuff, you're lucky if it'll last 1 or 2. And then that's why I'm doing the speed with it on top of it, because it'll make it last a bit longer, that little bit longer. And with the broader economic imperative to stretch drugs because people are deeply, deeply impoverished, we saw this reshaping of drug use practices. And so too, we can understand, again, these moments of critical drug supply transition as catalyzing moments in the reorientation of community drug use patterns and practices. Second, it's important to foreground that gendered and racialized dynamics within the broader drug scene can heighten specifically women and also gender diverse persons' vulnerability to everyday violence as the drug supply changes. And that measures taken to prioritize safety can in fact amplify overdose risk. And very specifically, something we've consistently seen in our work is that these patterns are particularly pronounced among the Indigenous women who use drugs that we're working with, where because of a broader set of structural vulnerabilities that they contend with to a greater degree, and because of especially structural racism within the persecution of the drug war, these things can further amplify their risks. And so in early work that we were doing, looking at gender dynamics of the overdose response and the rapid scale up of overdose prevention sites, which I'll talk about shortly, we documented the extent to which fentanyl itself would amplify risks of gendered violence. And quite commonly, women were reporting to us that the heavy sedation that they were experiencing, especially during this moment of drug supply transition, left them incredibly vulnerable when using drugs in settings or situations where they needed heightened awareness of what was going on and an ability to act. Still further, we saw how this could then lead women very specifically to seek to inject alone or use alone, which would horribly heighten their overdose risk because they were simultaneously contending and balancing this very immediate risk of violence and sexual violence in unregulated drug scene settings. The quote from one of our papers: "I wouldn't do it, consume drugs at someone's house I just met or alone in a public washroom, because my sister did that recently. And when she came out from nodding off, a guy was standing over her." And this was a common thing we were seeing expressed during this period of rapid drug supply transformation, which more recently we've seen in our work looking at quote unquote benzodope or illicit fentanyl adulterated with benzodiazepines, which effectively can produce a complex overdose event where someone can still be heavily sedated after naloxone administration because they're effectively knocked out on benzos. And so too, much as we see critical moments of drug supply transition marked by transitions in drug use practices, we can also understand these as particular moments characterized by heightened risk of gendered and racialized violence. Third, and consistently, and following a decades of work done specifically around HIV prevention and risk, we see that structural vulnerabilities that impact people who use drugs, including housing vulnerability and homelessness, can lead to disruptions to drug use patterns that can further undermine harm reduction. So, for example, one of the things that we've documented over time is how changes to people's housing, and very specifically residential eviction, can produce amplified overdose risk because of how it can disrupt everyday patterns and sociospatial practices. And so even within a 10-block area, displacement from one side of the drug scene to another can disrupt people's access to a familiar drug seller that they have a relationship with and risk communication around what's in supply that can then put them in situations where they'll be at greater risk of using drugs of unknown potency, and less able to take risk reduction measures. Still further, this can place people in positions where, because of these broader disruptions, they're more dealing with kind of an oscillating process of opioid withdrawal, of having the frequency with which they're using interrupted, the everyday regular patterns that they use to structure their lives, meaning that people are much more likely to be put into a position of using quickly, often drugs of unknown contents, because of the immediacy and need to alleviate opioid withdrawal. Still further, we found that how the broader sets of social supports and systems intended to, in many cases, address these things are set up such that people who are vulnerably housed or recently evicted spend so much time navigating these systems alongside navigating their opioid use that it can be horribly destabilizing because of how people are cycling from place to place and social system to social system that are disconnected and require intensive engagement over time that can make managing all of the other parts of someone's life quite difficult. So in terms of interventions, as mentioned, the Downtown Eastside in Vancouver has been a site where we've seen some of the more novel overdose response interventions implemented, going back to it being one of the early sites of the implementation of syringe exchange in North America, on through to the implementation of Insight, which was North America's first sanctioned supervised consumption facility in the early 2000s, on through to the rapid scale up of these interventions following a Supreme Court case and other changes within the context of a public health emergency that suddenly saw the number of overdose prevention sites, which were low threshold supervised consumption facilities, rapidly scale up in the neighborhood in late 2016 in response to rapidly increasing overdose deaths, on through to other interventions that we've seen piloted, scaled up, scaled back over time as the politics of the overdose response are navigated. And I'll kind of finish with some points around that later. But this has included programs that on a pilot basis have distributed hydromorphone to people as an alternative to illicit fentanyl, that have seen prescription heroin and prescription hydromorphone used within structured treatment programs, all oriented toward providing people with alternatives to a drug supply that is otherwise toxic and driving deaths. And so one of the things that we've consistently seen, and we've seen it specifically in relation to overdose prevention sites, but still further interventions, is that the rapid scale up has really harnessed community expertise and social solidarity and been critical to mitigating gaps in local harm reduction coverage, but also importantly, enhancing equity in the overall overdose response. So specifically, in relation to overdose prevention sites, so you'll see this is effectively a map of the Downtown Eastside. It's a very small area overall. The black dot that you see would have been Insight, the sanctioned supervised consumption facility that opened in the early 2000s. The white dot would have been a protest tent providing supervised consumption services that opened up amidst rapidly escalating overdoses. But really in December 2016, the provincial health minister leveraged a prior declaration of a public health emergency related to the overdose crisis to greenlight the rapid expansion of all of these other sites that you see in purple. Now, because these quite literally were in some cases implemented over a weekend following a call from the minister or someone from the minister's office, what they really needed to build off of was the deep community expertise in the neighborhood that had been built through decades of drug user organizing. So in the late 1990s and early 2000s, you had the Vancouver Area Network of Drug Users form, which had a history of civil disobedience, and the opening of unsanctioned interventions operated by folks who use drugs that rapidly led to this development of a strong community capacity in providing overdose response services that then could be leveraged as these were rapidly expanded out, because effectively you had a population of folks who were trained in naloxone administration, overdose identification, operating interventions, including supervised consumption sites. And effectively, this put people in a position of being able to operate these in real time. But also implementing these through a peer response model meant that people were best positioned to be responsive to the lived realities of folks who use drugs. And so what it's meant, for example, was doing things that perhaps weren't permitted at Insight under its exemption to federal drug laws, practices such as assisted injection, which many people who use drugs will need due to disability or decreased venous access or a range of other things. That meant using often naloxone as a last resort, as opposed to a first response, so as to avoid putting someone into active opioid withdrawal. This meant a setting or a space that people could go into where they would see people like them, that they could identify with, that they could share information about common community resources, that they could leverage to navigate the hardships of poverty and socioeconomic marginalization, that they could organize within, but also on a basic level that they could identify with. And so we've found consistently that peer-based models in turn ended up being particularly effective in attracting folks who use drugs. And then over time enabled a set of overdose response practices that were more humane. And so this meant, again, that people would work to manage overdose as much as possible without naloxone administration, that folks would be supportive, and often that post-overdose aftercare was being done by people who had that shared lived experience and could relate and be best positioned to assist people and manage these in a way that was responsive. So here's one of our participants talking about kind of this rapid opening. It was a great big thing. So like we were talking for hours, then we had extra meetings just to see what we can do, how we're going to do that. We had 24 hours to open up the room, and that was that. And so the urgency of the situation alongside this expertise could then produce a rapid real-time emergency response in the context of a growing crisis. Still further, one of the things that we found is this in turn could expand the scope of possibilities within any individual site. So for example, one of the sites that was a primary research site for us for a number of years started as an overdose prevention site, expanded in community-based drug checking and drug surveillance and real-time alert sharing with folks in the community. That still became a pilot site for a low-threshold hydromorphone program that I'll talk a little bit about in a moment, but became a comprehensive site that people could move into, between, and navigate the specifics of their substance use as it evolved, including as a bridge to low-threshold treatment. Still, too, we found that locating these in the community and within a broader spirit of community organizing and intervention meant that we would see an emergence of practices within these sites that in many cases were unanticipated. So for example, in relation to the implementation of drug checking at this particular site, one of the things that we ended up finding is that really the majority of folks who were using it were folks who were selling drugs, who occupied the kind of lower end of the selling market within our setting, who wanted to know what was in their drugs so they could better communicate risk to the people that they were selling drugs to, because they were part of the community they were working in and wanted as much as possible to protect the people that they sold to. Second, in relation to interventions, we found that effectively the effectiveness of these interventions ended up being constrained because of how it operated tension with the broader conditions of the drug war and the broader neoliberalization of public health. And so, for example, in work that we did looking specifically at policing in the neighborhood, we found that the patterns of place-based community policing that would locate officers close to or around sites were a deterrent from people accessing them, including when we were most concerned about particularly potent fentanyl or other drugs circulating in the community. And so consistently, we would see people disperse at moments of police intervention in and around sites. Second, while implementing peer-based models was instrumental in expanding access and creating broader conditions in which people could engage with services that they identified with, this was largely done on the backs of people who used drugs, and interventions themselves were under-resourced, and people were most commonly placed in positions where they were working as unbenefited casual laborers within these contexts, experiencing constant trauma of losing people within the broader community. And so this task shifting within public health that we saw happening through the mobilization of peer-based responses because they were underfunded, unbenefited, and didn't come with the broader supports that people in emergency medical professions would commonly have, produced tremendous burnout and in turn overdose risks among the very people who were instrumental in the community overdose response. So in relation to policing, for example, here's a quote that I think really kind of draws out what we saw. There are certain areas that you don't want to really be there because the cops will drive up and down and you never know what they're going to say or do. It's mostly the 100 block, which is the core of the drug scene. But they do circle around pretty well over the Downtown Eastside. But yeah, mostly in that area, there's a heavier presence in that area. And so this is very specifically the block where you have Insight, the Molson Overdose Prevention Site, the Maple Overdose Prevention Site, the single busiest syringe exchange in Canada, if not North America, and a range of other supports for people, was one of the most heavily policed sites within the community. Now, finally, talking more about the recent work we've been doing, looking at some of the more innovative interventions that we've seen recently. Really a point to emphasize is the people who use drugs are motivated to access alternatives to an unpredictable and toxic supply. And while advanced treatment and safer supply options have been instrumental in reducing overdose risk, they're often constrained because of the intersection of surveillance and broader dynamics. So specifically, what we saw is first the implementation of a pilot program within one of the overdose prevention sites that was dispensing hydromorphone to people enrolled through primary care. So effectively, someone could show up at this site here. You see the nursing window at the back. And folks who were enrolled in this program could show up and have 8 milligrams of hydromorphone effectively given to them for on-site consumption, which could be crushed and injected or snorted. It could be ingested. But the intention was to provide people with an alternative to otherwise going out and using an illicit drug that could be fentanyl, it could be fentanyl and something else, but always carried with it a heightened risk because it was unregulated. And so what we found in the work that we did, specifically looking at folks' experiences on this program, is people wanted alternatives to a supply that was toxic, even if they didn't otherwise desire being engaged in a treatment program, which could be structured by longstanding histories of trauma, specifically traumas in relation to treatment programs, broader impacts of a medical system that often acts out in a structurally racist way, especially to Indigenous folks who use drugs, and follows with it constrained care access, or because of people's priorities and goals at any given moment. And so here, regular access to something that was an alternative allowed people to limit their engagement with the illicit supply. It allowed people to structure out better drug use routines that could then translate into better drug use experiences, but also greater social stability. That it meant people had greater access to funds, which meant they could attend to other concerns, including eating, including wellness concerns, and more broadly, just reported a much, much better quality of life. And so then when COVID hit, obviously we saw many of the broader disruptions that happened everywhere else, which meant that there needed to be a nimble response. And so this meant that in the context of British Columbia, you saw the rapid development and release of risk mitigation guidelines in the context of overlapping COVID and overdose public health emergencies, which meant that folks accessing a prescriber, be it a physician, like a primary care person, an addiction medicine specialist, potentially a nurse practitioner, could have hydromorphone prescribed to them for the purposes of limiting their overdose risk and engagement with the illicit supply, for the purposes of COVID-related isolation, quarantine, during this period of transformation. So we did work looking at people's experiences once having accessed this version of a safer supply, that is a regulated drug, in contrast to primarily illicit fentanyl. And we found when implemented in this way, it produced many of the same positive impacts that we had previously documented in relation to the pilot hydromorphone distribution program. People were less likely to engage with the illicit supply. People reported better quality of life. But two, as we had documented previously with that program, that hydromorphone to illicit fentanyl, when someone has developed a dependency on the latter, isn't an apples to apples comparison. And this meant that this could best be understood as an intervention that could limit people's engagement, but because the potencies were different, wouldn't necessarily completely eliminate engagement with the supply, illicit supply. But interestingly, because people were then less likely to be going through these patterns of withdrawal that can characterize illicit opioid use in a criminalized context, when they did engage with the illicit supply, they were able to do so more safely. They were better positioned to be able to test smaller amounts of drugs because they weren't in effectively active withdrawal when using. Meaning that even if not fully replacing engagement with illicit drugs, it still was protective in the context of overdose risk. So here's a quote from one of our participants that really draws out some dynamics of these programs. I don't think anybody's overdosing on the safe supply program. You know, there's a standard of drugs that you know what you're getting when you get this. Here, if you get it on the corner, you don't know what you're getting. You might think you do, but you don't. I've been running the spectrometer, and I'm seeing all sorts of things in the drugs that I wouldn't want to put in my body. And so here, emphasizing the regulated access to regulated drugs conferred safety because of, again, the potency and toxicity of the supply. So really, if we cycle back, you know, what does this program of research tell us about the changes that will be needed to address the overdose crisis? And I think importantly, where do we go from here? I think first, it's that we need to attend to the broader social and structural conditions that can drive overdose risk if we want to intervene in a meaningful way. And certainly this means intervening around policing practices and the broader carceral logics that shape the lives of people who use drugs and in turn can amplify their overdose risks. But it also means addressing a broader housing crisis that certainly we're experiencing through much of North America and certainly in the Bay Area. It means building off existing community capacity and strengths in the implementation of nimble and responsive harm reduction programs and centering people who use drugs in their implementation. But doing so in a way that ensures that people don't effectively become workers taken advantage of, that they're adequately paid, that they're provided the supports that we need, and that their expertise is recognized and centered as essential healthcare workers. And finally, this means especially in the context of this ongoing emergency, treating it with the urgency that it deserves. And accepting that while there may be public opposition to some programs, which is largely ideologically driven, that they're necessary, that they're life-saving, and that they actually produce most of the benefits that people commonly say they want to see in drug-related interventions. They address overdose risks, but so too do they attend to some of the broader concerns around quote unquote public disorder, like public injecting, by providing people with alternatives. Like, as we've documented in our work around safe supply interventions, addressing crime, by leading people to be less dependent on engaging in criminalized activity to generate income to support their drug use. Now, at this particular moment, this isn't an easy task. Throughout so much of North America, we're encountering organized opposition to the very interventions that we need to keep people alive. And I think here, what we really need is to accept that in our roles as researchers, in how we engage with the community, in how we advocate for change, that we need to adopt strategies that build on existing community organizing and that put our work in service of the very people that we engage in with our work, and that ultimately are oriented toward capitalizing on existing strengths within the community to leverage research and in whatever way possible, with whatever entry point we see, to move things forward, because right now we have to. And so with that, I'm happy to take any questions, and thank you so much for joining and for listening.
Thanks, Ryan. Nice to meet you, and thank you for such an informative presentation. I had one question. When you were talking about the level of research that's been going on in the community there in Vancouver, and I noticed from the papers that you have multiple authors from lots of different institutions and organizations. How are you all managing the overlap and I don't want to say territoriality, but the issues? How is that going, and how do you make that all work?
Yeah, I mean, certainly I think that's an ongoing issue, especially, I think it was especially so as the overdose crisis first started to take off, because there was this rush of new people into work in this area because it was a quote unquote hot topic. I think over time, what really happened is we just developed better processes of communication across the researchers and research groups operating in the community, really so as to not, as much as possible, duplicate work. Now, this doesn't mean that that doesn't occasionally happen, but that also can be a strength in some cases by, generating still greater evidence to support something, or by allowing people, academically to maybe apply different lenses in terms of how they might be approaching a specific issue. But I would say, beyond that, the community-based organizations themselves, and especially the drug user unions, end up being a kind of pretty critical group in vetting research that happens in the community to some extent, and informing researchers if someone comes to them with a project that they're hoping to do, that somebody might already be doing that. And I think that's really gone a long way to addressing that. And I would say, over time, as much as I'd like to say that there's been improvements in kind of an ethic of community-based research in the community, and certainly there have been a number of initiatives led by kind of grassroots organizations to, for example, bring in kind of community processes around research ethics processes. I mean, COVID really slowed a lot of that and made it complicated in ways that we're still trying to get back to and kind of institute on a more meaningful level as we go forward. So all of this is to say, I mean, better communication, community groups knowing what's going on, but I mean, we still need to do better around this. And we need to constantly be reflexive around how we're engaged with the community and whether we're duplicating efforts in a way that can increase research burden.
All right, thank you.
Thank you. I have a question along those lines, if I may, Ryan. Could you tell a little bit about the actual methodology that you use? I mean, I assume you use interviews, in-depth interviews, and participant observations. So generally, what kind of methods and who are the participants in the studies?
Yeah, so, really I kind of deploy a range of different qualitative methods in the work. So always a combination of ethnography in the form of participant observation and in-depth interviews with people. But these are often supplemented or complemented by a range of other approaches, really using different elicitation tools, or different things, especially in an interview context, to deepen the work that we're doing and collect more precise data. So this can involve, for example, doing qualitative mapping exercises with people that will then integrate alongside community level overdose data to understand distributions of experiences set against where we'll see clusters of overdose deaths. It can involve using timelines depicting like changes in the drug supply over time to talk to people retrospectively about their experiences of overdose risk. So, effectively, always ethnography and interviews, but always trying to find other ways that we can deepen or better engaged with, for example, experiences of place or kind of spatio-temporal dimensions of overdose risk over time.
And I assume this is particularly drug users and their friends in the networks. So the work has not involved police officers, other agencies, non-for-profit health services agencies involved in the area.
Yeah, so we'll always privilege people who use drugs in our work and center the majority of the work that we're doing with folks with living experience of drug use. Now, certainly, depending on what it is that we're doing, we'll also look at people involved in the delivery or implementation of specific interventions, so as to kind of more broadly understand what's going on. I would say here, though, to be quite honest, ethnography is usually proven a lot more effective in these spaces at understanding dynamics related to service delivery more so than interviews with people involved in service delivery. Cops are a completely separate thing where just generally, both in solidarity with the folks that we work with and our community partners, but also because quite literally they will not talk to us, we generally, for example, wouldn't be doing work with them. But I would say here, this also kind of more broadly reflects back on how we might think about the ethics of community-based or engaged research in a neighborhood where people are both heavily researched, but where people are heavily policed and have frequent interactions. That I think if we were doing that work in a way that we were seen as being quote unquote on side with police, we just simply wouldn't be able to do it. And I think more broadly of an example of a research coordinator I had start years ago. So I had a research coordinator start, wonderful, wonderful human being, had been involved in community organizing, but was also coming into this role as his first professional job. And we did his orientation, low key. I had to be away, I think, for a conference. And then I think I had a rare vacation, which, I feel like is to be celebrated. And find out in the period of the 10 days that I was gone, as he was coming into work and doing data collection with people, he thought, I'm in a professional job. I'm going to dress up, going into the office. I got a new haircut and was going out doing, effectively come along interviews with people, walking around the Downtown Eastside, talking with them about their experiences. And he got, 4 or 5 days in, and finally someone was like, dude, I can't walk around with you. You look like a cop. Like, people are going to think I'm a CI, you're putting me at risk. And so, that really draws back to me, we need to be sure that we're doing this work in a way that we're effectively seen as being on side with the people that we're working with, so as to both have research access, but also to do the work in solidarity. I think
There's a question in the chat.
Yeah. Okay, so I see a question from Dr. Lorbeck. Can you give some examples of how community partners are involved in your qualitative research? For example, they participate in developing guides or data analysis. So yes, so I'll draw an example. So when we were doing this work around evictions in the Downtown Eastside, the whole of the project was participatory. So we generated the idea and quite literally the grand aims across a series of meetings that I did at Vandu I would get pizza or Chinese food, and we would sit around and talk about what are the priorities, what we need to look at, how should we be looking at this, and what should we do. And people would especially be very concerned with, well, I want to tell my story, but what I'm experiencing and have that elevated is important. So we're like, okay, so we'll do qualitative interviews. We'll do these at a couple of points because people are like, well, our experiences change immediately following eviction to several months later. So we should really think about how these impact people over time. Still further, you know what? Some of the stuff that happens is illegal. So why don't we bring in some lawyers on the study team so that we can do socio-legal analysis of the qualitative data as well? And so we did the whole of the project together. We wrote the grant together. We designed the interview guides together. Folks who use drugs were hired as part of the project as researchers. They did recruitment with us. They did interviews with us. And, because people's computer literacy skills weren't there and we weren't able to get them, they didn't do coding, but we developed the coding frameworks and interpreted the data together so as to best ground it in the broader context of community experience. And so really what participation is like can vary project to project. That's probably the example of where we've best done it. Now, certainly as the overdose crisis has worsened over time, one of the things we've certainly found is that we have to stagger opportunities in certain ways because of how community members can be overburdened when becoming engaged with us. So we, mobilize a range of different approaches to best suit what people need and how they can best engage in a way that's sensitive to the trauma that they're living through, and best able to be mobilized toward impact.
All right, I think we have arrived to the end. There's no urgent questions or topics. Please respond if you can. Please respond to Rachel's or Stuart's survey. We love your input. Your input helps us a lot to improve these town halls. Thank you, Rachel and Stuart, for organizing this, and please help me give very, very much. Thank you much to Ryan for wonderful, insightful presentation. Thank you, Ryan. And thank you everyone for joining us this afternoon.
Wonderful. Thank you all so much for joining. And thank you for having me.